sort of give you some of the tools to navigate your way through the conference, and also an overview of what the conference is going to be like and what the speakers are going to be speaking about. I think that I won't spend a lot of time introducing or talking about who the speakers are, because you'll have introductions as each talk comes along, but I wanted to at least link you up so that you understand who the different people are that are going to be talking in the conference over the next couple of days. So first, I'm going to talk about all the major aspects of HHT, and this is what we're going to be talking about over the next over today and tomorrow. Is everything from nosebleeds to brain AVMs and HHT, and we're going to be presenting this with up-to-date 2021 information related to diagnosis of HHT, to treatment of the disease, and to research in HHT. You're going to be hearing from expert doctors from HHT Centers of Excellence who've kindly agreed to take some time away from their weekend to come and speak with you today. There will be speakers from Vancouver, from Edmonton, Calgary, Toronto, and also from UNC Chapel Hill. You're also going to be hearing insights from an HHT PhD scientist in training, our very own Anthony Canavici. So that will be really exciting to hear his talk and his view of HHT research advances. And you're going to be hearing along the way and connecting along the way with the dedicated volunteers from HHT Canada. So specifically, in this talk, I'm going to define what HHT is, not only the disease, but also the terms, because unfortunately, this disease is sort of encumbered by a lot of difficult and tongue-twisting terms. So we'll make sure that we make them all as clear as we can for the coming presentations. I'm going to talk a little bit about how we diagnose HHT, the different ways, and then I'm going to give a bit of an introduction to HHT by organ, in other words, by the different types of symptoms or different parts of the body that are affected in HHT. And I'll close by summarizing some of the other aspects of the overall aspects of HHT care that we're going to be talking about during the conference. So first of all, what is HHT? I've said it's encumbered by difficult terms. It's also got several different names just to confuse the issue. So currently we use the term HHT, which stands for Hereditary Hemorrhagic Telangiectasia. But for many years, and still in some places and in some literature, it's referred to as Osler-Weber-Rondeau disease, or the order can be mixed up, Rondeau-Osler-Weber disease, or variations on that. Some people also call it Rondeau-Osler disease or Osler's disease. And a lot of that has to do with who you're speaking to and whether they're, which of those early clinicians they're most proud of, depending on what country they're from. But, you know, really, as much as it's a mouthful, hereditary hemorrhagic telangiectasia, it is the only one of these names that really explains the disease. And this is why it's been the preferred term in recent years. So what does HHT mean? So the three words of HHT, I want to explain each one of these individually. So hereditary is something you get from your parents through the genes that they pass on to you. And there are three genes that we know are associated with HHT, the endoglin gene and the ACVRL1, or people used to call this ALK1, if you've heard that term, it's the same thing. The endoglin gene and ACVRL1 genes make up for 80% of the HHT mutations that we see in HHT, at least 80%, maybe even 90%. And then there's about 3% of families that have a SMAD4 mutation. And I'll talk a little bit about these further along. But that's the hereditary piece. Each family has pretty much their own mutation or their own change in one of these genes. It's sort of like the private mutation or the private key to each family with HHT. And then the next word is hemorrhagic, and hemorrhagic means a tendency to bleed. Okay, and we tend to use in medicine the word hemorrhage when we mean a heavy bleed, but hemorrhagic just in this context just means a tendency to bleed. And then the third term, probably the most tongue twisting of all, is the telangiectasia. And this is, you know, a lot of medical terms are based on Latin words, and this is one of those examples. So telangiectasia is made up of three Latin components. That one is TEL, which means the end, which means blood vessel, and ectasia, which means deformed. So basically it's the end of a blood vessel that's deformed or malformed. And so in this little picture that I've shown down, that I've shown down here, you see that, and let me explain this. This is a piece of an angiogram. So a test in medical imaging or radiology where we inject X-ray dye into the person to light up their blood vessels. So everything that's black in this image is a blood vessel that has dye in it. And these are blood vessels in the lungs that as they branch out and get smaller and smaller, they look like they're little branches of a tree. And that's normal, okay? But here you see a blood vessel that has a deformed kind of lobular end to it. That's an AVM, or the larger version. It's the larger version of what we call a telangiectasia. Okay, so this is the example, a nice visual example of a deformed end of a blood vessel. And that's what telangiectasia means. Okay, so we've talked about sort of the definitions of the words. What does this mean in terms of the disease? So HHT is a disease. It's characterized by these telangiectasia, the abnormal blood vessels, and their larger versions, which are called arteriovenous malformations. They're the same thing. It's just a question of size. So these are some pictures of very small lesions, telangiectasia on the lips and tongue and finger of an HHT patient. It's not always this obvious. You know, you'll find that in medical presentations, people will show obvious cases because they're just easier to present, okay? But sometimes there might just be one tiny telangiectasia like this on like one of these little ones on the lips, and that might be the only telangiectasia that someone with HHT has. So, but the disease is characterized by these telangiectasia on the mucosa, which means the lining of the mouth and the nose and the GI tract. Those are all called mucosa, or on the skin, which you'll sometimes hear people refer to as cutaneous. You will not be tested on these words, okay, on the medical language, but I just wanted to demystify some of it where I can. And then the arteriovenous malformations, or AVMs, are the larger abnormal vessels that we can find in the organs with people with HHT. And this is an example, again, a dramatic example of an angiogram from the lung. This is the entire lung of a patient who had multiple large lung AVMs. And I think you can see from my description before, these are normal blood vessels, these are AVMs, all these larger lobulated structures. And this is an angiogram of a brain showing a brain AVM. So see, these are some typical types of lesions that we can see in HHT patients. So just to come back to the basics of HHT disease and what causes symptoms in HHT, I mean, people with HHT have many normal blood vessels with normal structure. Like I showed you in that angiogram of the lung, we saw normal blood vessels, and then beside that AVMs. People with HHT, though, will have a small number of blood vessels that are deformed or called malformations or telangiectasia. And the symptoms and signs of HHT depend on the number and the location of those abnormal blood vessels. And then, you know, in the areas where the blood vessels are normal, there isn't a tendency to bleed. So it's not a bleeding, a blood coagulation disorder, but a blood vessel disorder. And that's something that sometimes doctors and other healthcare workers that don't see a lot of HHT, they don't even know that about HHT. They think it's a coagulation disease, but it's actually a disease of malformed blood vessels. And the symptoms come from those abnormal blood vessels. Sorry, okay, got it, okay. So the common features of HHT are related mostly to the telangiectasia that we've talked about. So and when we talk about telangiectasia on the skin and mucosa, we know that about 90% of adults with HHT will eventually have these. Okay, so not, it's symptoms and signs of HHT, particularly the ones on this slide, these common features of HHT, tend to be age related. So if we look at a group of people with HHT that are 20 years old, only about half of them will have telangiectasia that we can find on the skin and mucosa, and only about half of them will have nosebleeds. But by the time we get to a group of HHT patients who are about 50 years old, it's about 90–95% that will have both of these very common features of HHT. So that's what we call age-related expression. And that is a feature of HHT, and it makes HHT easier to diagnose clinically in older adults and more challenging to diagnose clinically in children and young adults. In addition to those common features of HHT, which help us to diagnose it, there are a number of unrecognized or often unrecognized features of HHT, and they relate to the AVMs in the organs. So the AVMs, or the arteriovenous malformations, as I've defined, in the organs, they can often go unnoticed until they cause a complication like a hemorrhage or a stroke. And there's an important role for prevention related to organ AVMs. And organ AVMs are actually, though they're often unrecognized, they're not rare. Brain AVMs occur in 10% of people with HHT. Lung AVMs are present in 40%. GI tract, or the gastrointestinal or digestive tract, meaning stomach and bowels, we'll find HHT lesions there in 30% of adults. It's usually, just to clarify, usually the lesions in the digestive or GI tract are smaller lesions, more like telangiectasia, rather than large AVMs, but they still are often unrecognized features of HHT. And then HHT often affects the liver. Again, it's mostly telangiectasia, so patients will have many small telangiectasia in the liver. And if we look really hard, we can find that in 75% of people with HHT, though I'll come back later to the fact that most of these patients don't have symptoms of those liver telangiectasia, only a small percentage do. So these are the often unrecognized features of HHT, but they are also common features of HHT. And we're going to spend quite a bit of time over the next few days talking about some of these organ AVMs, because as I've said here, that there's an important role for recognizing these, for turning them into recognized features of HHT, and for preventing complications. So first of all, what is the very first step in prevention in HHT? It's diagnosing the HHT. So even in 2021, there are many people with HHT and families with HHT who have not yet been diagnosed. And some people listening to this call might be in that situation where they're unsure whether they have HHT, or maybe not everyone in their family has been sorted out as to whether they have HHT or not. And that's a really critical feature, because you can't, really critical step, because you can't really start to prevent the complications of HHT until you know whether someone has HHT or not. So how do we diagnose HHT? This is a bit of a visual abstract that I prepared to try and help teach clinicians about diagnosing HHT. And there are really two ways to do it. We either use clinical criteria or we use genetic testing. And it's not like we just decide, flip a coin or say, what do you want to do today, clinical or genetic? I mean, there are specific situations where we use each of those. So clinical diagnosis is usually is if we can make the clinical diagnosis in someone who, the first person we see in a family with HHT. So let's say, first person in the family who comes to an HHT clinic, no one in that family has ever been assessed for HHT before. And if we see them in the HHT clinic and we can confirm the diagnosis clinically, then we call that person the index case in the family. So we now know that there's HHT in this family. And that's really the cornerstone of HHT diagnosis. We start with an index case in the family. Once we have an index case, then we can use genetic testing. So let me explain what I mean by clinical diagnosis. So the clinical diagnosis of HHT is based on 4 diagnostic criteria. And these are sometimes called the Curacao criteria, from when we first published the HHT diagnostic criteria a little over 20 years ago, actually. So the 4 criteria are a family history of HHT. The second one is recurrent spontaneous epistaxis or nosebleeds. And there's some specifics about how we define that, but basically it needs to be a chronic and recurrent problem, not just one episode or not just a recent history. And then the presence of organ AVMs, as we've talked about, and presence of even one organ AVM meets this criteria. And then finally, the presence of multiple typical telangiectasia. So here we expect to see more than one telangiectasia to count this as a criterion for clinical diagnosis. If we find 3 of these criteria in somebody, then we can call this a definite clinical diagnosis. if there are only 2, it's not that we're saying they don't have HHT, we're just saying that we haven't been able to confirm it. And of course, as I mentioned earlier, if we were trying to start with a child or a young adult, we might have a very hard time getting 3 criteria to confirm a clinical diagnosis. So sometimes it means seeing older people in the family to confirm the clinical diagnosis in somebody. But once we have a confirmed clinical diagnosis in someone, they don't need genetic testing to further their care. But we often will send them for genetic testing so that we can identify the key to their family. So if we can figure out the mutation or the change in the gene that causes a person's HHT, then we can test other people in the family, people that don't necessarily that don't have nosebleeds or symptoms, for example, or other symptoms of HHT. We can test them for that mutation, and we can either rule in or rule out the diagnosis of HHT. So this is the key first step to prevention in HHT is diagnosing making the clinical diagnosis in an index case, finding the mutation in the family, and then checking everyone in the family to sort out whether they have HHT or not. Because HHT is a dominant genetic disorder. So it means that about half of the family has HHT. So it's a very significant step once we know a person has HHT. The next, a very significant next step in their family's care is to inform people that they all are at risk of having HHT. So, the genetic test is most useful for the people in the family who don't have symptoms. So then they can get checked for the gene mutation that's been discovered in their family, their private mutation. And if they don't have it, then they don't have HHT. The people that have nosebleeds in an HHT family may not need to get genetic testing. They would be better off going right to getting clinical care for their HHT. Okay, I'm going to spend the rest of my time just talking about the clinical aspects of HHT. And also, as I mentioned, sort of pointing to the talks that you'll be hearing over the next couple of days regarding these clinical aspects. So nosebleeds in HHT, as I've mentioned, are a very common feature. And I think, I'm sure that most of you are nodding your heads. And nosebleeds can range in severity, of course. For some people, it's a nuisance, just a nuisance. For many people, though, it can affect their quality of life, affect their daily functioning. And in some people, they can have severe episodes that lead to emergency room visits. And in many people, the chronic bleeding from nosebleeds can lead to iron deficiency and anemia. Over the course of the conference, you're going to be hearing about nosebleeds and their management, as well as management of iron deficiency and anemia from several of our speakers who I've listed on the right here. But just to summarize, where as a starting point, often we'll say the very first line for care, nosebleed care for people with HHT is protecting the nose. And we'll talk more about this over the next couple of days, but moisturizing the nose and protecting it from injury so that those blood vessels are less likely to get damaged and bleed. There are, however, a range of available treatments for nosebleeds that are more than nuisance nosebleeds that range from multiple different medical therapies we can consider and multiple different surgical therapies. And these range from less invasive to more invasive, depending on the severity of nosebleeds and how people have responded to therapies, the sort of first line therapies. So we will definitely be talking more about this over the coming days. I'm going to skip next to lung AVMs because they're a common feature of HHT. As I mentioned to you before, about 40% of patients with HHT have lung AVMs. And this is one of our key pieces of prevention in HHT. So just to come back to what an AVM is. So this is an angiogram again. So a procedure in radiology where we inject X-ray dye into the blood vessels of someone with HHT. But now we're kind of really close in, and they've put this catheter tip right into the feeding artery of an AVM. So this is a much blown up picture, whereas this AVM feeding artery is probably about, like it was about a 5 millimeter feeding artery, like about 5 millimeters in diameter here, okay? So but I've blown this up so you can see it. And I wanted to show you that this is the feeding artery, this is the aneurysm, and this is the draining vein. Those are the pieces of a lung AVM, or the components of a lung AVM. And it's a bit confusing because there's the term aneurysm in here, and a lot of people who don't have HHT can have aneurysms in different parts of the body, and we hear about that, people having a brain aneurysm or an aortic aneurysm. That's a different problem than what we deal with in HHT. But aneurysm itself is just a medical term describing a vessel that's sort of stretched out. Okay, so this part here is the stretched out part at the end of the feeding artery of the AVM, and that part is called the aneurysm. But the whole lesion here is called the AVM, and that's what we'll call it from here on in, okay? So about 40% of people with HHT have AVMs in the lungs, so it's really not a rare complication for people with HHT. Lung AVMs often cause no symptoms until they cause serious complications. So, so we really like to find out before they cause complications whether somebody has AVMs in the lungs or not. The types of complications lung AVMs can cause is bleeding into the lungs or brain complications, such as stroke and brain abscess. So the key to lung AVMs is prevention. It really revolves around screening every person for lung AVMs and treating them preventatively with embolization. You're going to be hearing about this shortly from Dr. Telangiectasia and Dr. Owen from the Edmonton HHT Centre. And when we summarize at the end of the conference and come back to HHT care in Canada, I'm also going to point to the HHT guidelines where we have very clear recommendations for screening and treating for lung AVMs. Brain AVMs and HHT are present in about 10% of people. Again, I mean, rarer than lung AVMs, but not rare. These can lead to serious complications, such as bleeding in the brain or stroke and seizures. And again, the key really is in prevention. The key is to screen all patients with HHT for brain AVMs and to consider treating brain AVMs. This is a little different than lung AVMs in that it's not clear that every brain AVM should be treated preventatively, but it is clear that we should always consider treating brain AVM preventatively. And that should be considered with experts, a team of experts, with the patient and their family, and through a careful weighing of the risks and benefits. And you're going to benefit from the presentation from expert Dr. Timo Krings regarding brain AVMs and HHT. And again, as I mentioned, we will come back to the current HHT guidelines recommendations in this regard as well. GI bleeding in HHT, so if I remind you, GI is gastrointestinal, which means stomach and bowels. GI bleeding in HHT is present in about 30% of older adults with HHT. It's not typically something we see before age 40, more commonly after age 50. And in the over 50s, it's about 30% of people. And the primary thing that GI bleeding in HHT does is lead to iron deficiency and anemia. It actually doesn't cause pain usually and doesn't often cause visible blood in the stool. So often people have no idea that they have this problem, except that they have iron deficiency or anemia. And it could be, one of the things that clues for us is when the iron deficiency or anemia is out of keeping with the nosebleeds. And also being in that age group where we think, well, people are at a bit of higher risk. As I mentioned, the GI bleeding in HHT is not from large AVMs, but from small telangiectasia. Of course, you don't have a size comparison here, but this is a lesion that's just a few millimeters in size. And this is a photo that was taken during an endoscopy, so a procedure where they put a camera down in through the mouth, down into the stomach, into the small bowels. And this was a typical HHT lesion that was seen by one of our gastroenterologists. So the keys to managing GI bleeding in HHT, we do use endoscopy, or that sort of camera test, as I was saying, and various versions of it to diagnose HHT of the GI tract. And sometimes we treat with endoscopy, though currently it's not recommended to treat repetitively with endoscopy, but rather if somebody has HHT-related GI bleeding, we need to make sure they get the iron supplementation and the treatment of their anemia that they need. And then we need, if they're still anemic, if we're not able to have it under good control, then we need to consider medications. And there's a range of medications that we can consider depending on the severity. And this is something that's going to be discussed in my session tomorrow, and also in Dr. Kasturi's session on anemia and iron deficiency management. And of course, we'll come back to it when we talk about the guidelines as well. Liver VMs in HHT, and you'll notice that I dropped the A here, and I'm calling it liver VMs, and this is the first time I'm explaining this. So I did mention to you earlier that the lesions in the liver are mostly small lesions. They're not big AVMs like we can see in the lung and brain, but they're telangiectasia. And really, it's a continuum of disease in the liver in HHT. So as I mentioned, most people, like about 75% of adults with HHT, have liver telangiectasia. And you know, there's probably a range from having sort of 10 telangiectasia in the liver, which are really not going to cause any problems because there's so few, and they're and in the liver, they're in this sort of protected capsule, so they don't bleed and they don't get traumatized. But there's a range of, 10 telangiectasia, 100, and maybe, up to even thousands of telangiectasia. So when somebody is over here with thousands of telangiectasia in the liver, that causes very high blood flow through the liver and can cause complications. And I'm going to describe those types of complications, but that occurs in about 10% of people with HHT. So it's not 75% of people with HHT who develop that, who have that kind of severity of liver vascular malformations, but that 10% that do can have significant issues with it. And those issues are primarily cardiac issues. So it's mostly that the liver vascular malformations, and I call them that because they're not big AVMs, and it's not just individual telangiectasia, but sort of a lot of telangiectasia or clusters of telangiectasia. When patients have a lot of liver vascular malformations, that causes a lot of shunting through the liver, so high blood flow that's going quickly through the liver and back to the heart, and that puts strain on the heart. So that 10% of patients who have complications from liver vascular malformations mostly have what we call high output heart failure. And it's not, I don't mean by heart failure, because that word failure it implies different things to different people. And I don't mean a cardiac arrest or heart attacks. What I mean is that the heart is having a hard time doing its job. It's getting a bit overloaded with fluid, and it stretches, and it has a hard time pumping the blood at the rate that it needs to, so that it doesn't stretch more, or fluid doesn't get backed up into the lungs or in the legs. So that's kind of what we mean by heart failure. I'm going to talk some more about it tomorrow in my session as well, but that's the main sort of issue that we can see with liver vascular malformations. And there are also some people who will have pain over the liver, and fluid collect in the belly is sort of a typical sort of, it looks like cirrhosis, but it's not. So they have complications of liver disease. So all of this I know sounds pretty scary, and it can be. But this is a rare subset of patients, and we are beginning to have better and better therapies for these complications from liver vascular malformations. So 10 years ago, our only option for patients who had very severe liver vascular malformations, and if we couldn't control their symptoms with medications, because we often can. For example, if someone presents with heart failure, we usually treat the heart failure with typical heart failure medications. And often that helps control the symptoms. But if it doesn't, or if the presentation is more these sort of liver type symptoms, we used to have to consider liver transplant as kind of our next step. But now we actually have some newer therapies called anti-angiogenic medications that we consider in people that aren't responding to first-line treatment. So we do have different approaches now to treat symptomatic liver vascular malformations. We don't treat liver vascular malformations preventatively in 2021. So we don't treat them unless they're causing symptoms. But once they cause symptoms, we have options. A couple of other topics that we're going to cover over the next couple of days are the care of patients during pregnancy, of HHT patients during pregnancy and delivery. I put this, my little icon that I put up here to remind me to not only mention that we're going to talk about the new HHT guidelines, because the 2020 HHT guidelines addressed pregnancy and delivery care in HHT for the first time. So not only are we going to talk about the guidelines-based recommendations, but I put this little icon up because this is actually an icon from the hhtguidelines.org website, which is a website that Cure HHT has supported and has set up for the HHT guidelines to make the HHT guidelines accessible to everybody, to doctors, nurses, dentists, patients with HHT. And any of you can go and look at that website and fully download the guidelines at any time. And not only that, with Cure HHT, we've developed these patient care checklists. So this is a little icon. You're not supposed to be able to read those words up there. It's just a little icon to remember to tell you about the HHT care checklists. And I'll come back to this tomorrow when I talk about the guidelines again. But these are tools that people can use to take to their doctor to educate their doctor about HHT, but also to make sure that people are getting the care that they should, the guidelines-based care that they should be getting for their HHT. So we've done that for pregnancy, but also all other aspects of HHT. So back to the specifics of pregnancy and delivery in HHT. Usually pregnancy and delivery in HHT should be normal and healthy and low risk, but there is some prevention required to make that, to be able to say that. The key to a low risk pregnancy in HHT is having up-to-date screening and treatment for AVMs, in particular lung and brain AVMs. And we're going to talk about that again as over the next couple of days. I feel like I've said that a few times. Dr. Andrea Lausman is going to be talking about this topic specifically, and we will come back to it in the guidelines as well. The other key to low risk, or the other important feature of care in the pregnant patient in HHT is for them to have access and to be able to discuss family counseling ahead of pregnancy, during pregnancy, etc., and the options for HHT diagnosis and prevention for the baby. I haven't talked much about children, but I haven't forgotten them. In fact, we made them a priority for the 2020 HHT guidelines as well. So you will be hearing about the care of children with HHT and what the current guidelines are. And you'll be hearing from our pediatric HHT Centre director here in Toronto, Felix Ratchin, about this. And he's a leading world expert in pediatric care in HHT and led the pediatric section in the HHT guidelines as well. I think the key things to know about childhood disease in HHT is that children with HHT have similar risk as adults do of having lung and brain AVMs. And Dr. Ratchin will talk more about what the risk is of those causing complications and how we should screen and treat them. But the bottom line is that the keys to pediatric care in HHT is to, first of all, know whether a child has HHT or not. And often we need genetics for that, because often they don't have nosebleeds or telangiectasia to help us, to help us know whether they have or don't have. We can't count on that to rule out HHT, given that most kids or most people with HHT develop those symptoms later. Of course, if they have typical features of HHT, that might help us confirm it. But most of the time, we're talking about using genetics in the infant or in a child as soon as the HHT diagnosis in the family is discovered, to rule in or rule out the diagnosis. So once we know if they have HHT, then they should be screened for lung and brain AVMs, just as adults should. and that preventative treatments should be considered with an expert team. So a couple of other topics that we're going to cover over the next couple of days are not only all the ones I've just talked to you about, but also the HHT guidelines-based diagnosis, screening, and care. And we're going to spend some time, a little panel session where we're going to talk about HHT centers in Canada, sort of how they work, and you'll hear from a few of our HHT center doctors about HHT care in Canada. And then, of course, we can't have a conference in 2021 without talking about COVID. So we will share some COVID advice for people with HHT, and we have a panel discussion about that as well. And then finally, you will hear from Anthony Canavici about HHT research from his perspective. And I think you will hear in each of the talks about some of the ways that we are currently advancing HHT care through research. So I want to thank you for your attention and your attendance, and I really hope you all enjoy the conference. I think that we have a few minutes for questions, and I'm happy to take a couple of questions, or we can wait and keep the questions for after the topic, the specific topic presentation. So I will leave it to our moderators to decide. Thank you very much.
Thank you very much, Dr. Faughnan. A very informative and descriptive talk. So we do have a couple of questions. We have two specifically, but before I jump into it, because a number of people have joined now since we started, I just want to go over very briefly how we ask questions. So for those of you at home, what you do is you go to and press the chat button on the bottom of your screen. This will bring up a box on the right-hand side of your screen. Where you type a question, just above it, it'll have colon, and you have a drop-down arrow to the right of that with someone's name. Click that drop-down arrow and please select the individual that is named AA question moderator. Please direct questions to this individual. So I hope that was clear. I will proceed to ask some questions now. So we have one question. Can an individual be positively diagnosed with HHT if the person does not have the gene found in the family? And they provide an example. If the mother has an endoglin mutation, but this mutation is not present in the daughter, could the daughter still have a clinical diagnosis?
So the answer should be no. Okay, so but the reason I say should is because no test in medicine is 100%. So if a mother has HHT and she has a clinical diagnosis of HHT and she's had genetic testing done and her mutation has been identified and her daughter is tested for that same mutation and doesn't have it, then normally we would conclude that the daughter does not have HHT. But if the daughter has all the typical features of HHT and has been clinically diagnosed with HHT, that trumps the genetics, and it makes us think maybe there is a problem with the genetic diagnosis in the mom. Okay, so as I mentioned before, each family has their own private mutation. So it's actually quite a challenging thing for the lab to find the mutation that causes HHT in a family. They basically look at, they spend 4 months studying the gene in the index case and looking at their HHT genes and looking at all the changes in those genes. And then they have to classify those changes, because everybody has changes in their genes, as normal ones or ones that cause disease, which we call mutation. And sometimes they can't classify it and they put it in the middle and they call it a variant of unknown significance. So it just might be that in the situation you've described, if I were seeing that family, I would say, hey, we need to go back to the drawing board here and make sure that what we've called the mutation in the mom, that make sure that that's in fact the mutation, because maybe it isn't. Maybe there's a different gene change that's the disease causing mutation in the family.
Thank you very much, Dr. Faughnan. I'm pretty sure that answered the question. It was a very good response. We have a question here. Do insurance companies have access to genetic test results?
So they don't routinely have access to genetic test results. They don't automatically have access, but if you apply for insurance and you say I'm followed by, and you have to talk about your healthcare and your diagnoses and what medical issues you've had. Then you say, okay, I have HHT and I'm followed by Dr. So-and-so for my HHT. And then the insurance company will ask you to sign a release so that they can get the records from that doctor from your care. So they don't automatically have access to it. But if you say yes to the insurance company that they can access, that they can contact your physician, that your physician can release information about your care, then it's probably included in that doctor's letters, that you have. For example, if you're being looked after for HHT, whether it's about the mutation or not, it'll say that you have HHT in the doctor's note, and it may also say what your disease-causing mutation is. So in that sense, typically, yes, if you have HHT and you're applying for insurance and you sign the release, then your insurance company will have access to that information.
Thank you, Dr. Faughnan. We have more than a few questions. We have to start the next session around 11 a.m., so we'll get through a few more. What is the relationship between HHT and anticoagulants or blood thinners? Is there an additional risk in taking these types of medications? Is there a relationship between blood clots and HHT?
Those are really good questions. And I think that it would be really good to leave those questions for Dr. Kasturi's session, because that's absolutely his area of expertise, and I'm sure he will be happy he'll be detailing those things, and he'll be happy to answer those questions. So let's defer that one. It's a good series of questions, though.
Is it important to know what gene the family has?
It is important in the sense that not necessarily what gene, but what gene mutation. So what specific gene change is present in the family is the key to diagnosing the people in the family, particularly those that don't have symptoms yet. And so, as we talked about, when we have identified HHT in an individual, we generally recommend that they have genetic testing done if they're the first person in the family, so that we can find the gene change in their family, the mutation. And then let's say that person has 3 20-year-old kids. We'll say, look, and none of those kids have nosebleeds or symptoms suggestive of HHT. Then we'll say your 3 kids, each one of them has a 50% chance of having HHT, and they should be tested for that genetic mutation to rule in or rule out the HHT. So that's the way that it's important. Now, there's another way I could answer that question, because sometimes people have talked about what we call genotype-phenotype correlations. So it is the case that we know that certain genes have more connection to certain aspects of HHT. For example, families who have endoglin mutation are more likely to have lung and brain AVMs. And families that have ACVRL1 mutation are more likely to have liver vascular malformations and GI bleeding. But those, the fact that somebody has an endoglin mutation or ACVRL1 mutation doesn't change the care that I recommend to them. Because everybody, whether endoglin or ACVRL1, is at risk of all of those types of complications. And so we screen everyone for lung AVMs and brain AVMs. And we take the same approach to liver and GI, whether people are endoglin or ACVRL1. The one last little thing I want to answer about that is that the third gene that can be mutated in HHT is called SMAD4. And SMAD4 is a rare subset of HHT, and it's often connected to another genetic disorder called juvenile polyposis. And without going into a lot of detail or spending a lot of time on that, If people have SMAD4 mutation, they need to get checked for both diseases. So that does actually change the advice. A SMAD4 mutation in the family suggests that people should not only have all the routine recommended HHT screening and treatment, but they should also get checked for juvenile polyposis. Thank you.